presentarnos el tema de tratamiento multimodal de cáncer metastásico en sistema nervioso central. La realidad es que es diferente ver a un profesor que viene a dar un tema y tener el privilegio de verlo hoy trabajar en el quirófano. El doctor Chaichana, a pesar de ser bastante joven, tiene una experiencia y un manejo quirúrgico extraordinario, así que estoy seguro que vamos a disfrutar mucho su plática. Okay. Thank you very much.
Thank you for having me here. It's a great place. It's the second time I've been to Mexico City, and despite being to Mexico several times, my Spanish is very bad, so sorry I can't speak in Spanish. The only words I know are muy mal palabras. So today I'll talk about one part of my clinical and research that I'm focused on is metastatic brain tumors. So the reason I got involved into metastatic brain tumors is because in neurosurgery and neuro-oncology, a lot of the focus is really on gliomas and skull-based tumors. So a lot of the basic scientists, they like to focus on gliomas because that's where a lot of the attraction for brain tumor surgery is. Those tumors that Dr. Quiñones presented, those tumors have very bad prognoses, and a lot of people like to study those tumors. For the surgical side, most people like to study skull-based tumors because those are the more elegant surgeries, such as the craniopharyngioma presentation. So the metastatic brain tumors, unfortunately, has been well forgotten because a lot of people think that these tumors are easy to resect, but no one really cares about them from a basic science standpoint because there are a lot of different types of tumors that encompass the metastatic brain tumors. So clinically, we've done a lot of research on this, but metastatic brain tumors in the United States and elsewhere is a very epidemiological problem. It's the most common type of brain tumor. In the United States, there are about 200,000 new cases in the United States each year, which is about 10 times more common than gliomas. So in gliomas, there's only anywhere between 10 and 20,000 cases in the United States each year, but for metastatic brain tumors, there's 200,000 cases in the United States each year, and that number is expected to rise. Patients who develop metastatic brain tumors have worse outcomes. This is a paper we submitted to JAMA Oncology that basically we study the SEER database, which is the surveillance database for the United States. And what we found is that patients who develop metastatic brain tumors, regardless of their systemic disease, have worse outcomes. The problem, however, with studying metastatic brain tumors is they're not all the same. Most people like to categorize them into the same category, but really they're all different types of tumors. So the most common primary locations are the lung, breast, melanoma, renal, and GI. But even among these organ systems, each type of metastatic tumor is very different. So in the lung cancers, you have adenocarcinomas, large cell carcinomas, small cell carcinomas. Breast, you can have carcinomas and different types of squamous cell carcinomas. So these tumors are very heterogeneous, even though they're grouped into the same category. And you can see here studies on the side. We can show that each of the tumors have different prognostic factors in terms of local survival and local recurrence. Each of these tumors have disparate responses or different responses to radiation, chemo, and immunotherapy. And the median survival, you take them all together, even though it's not really good to group them together, the median survival is 9.3 months. And among these tumors, non-small cell lung cancer have the best survival after surgery and radiation therapy. Local progression-free survival, that's after you do surgery and radiation, it's 84% at 12 months, which means about 15% have local recurrence. Among the different types of tumors, renal cell cancers have the best local progression-free survival. Distal progression-free survival, what that means is when you cure the primary site, do they develop sites elsewhere within the brain? And as you can see, 55% have control at 12 months, but 32% of the population that we did the study on had distal recurrence. So once they have one tumor and you resect it, they have new disease elsewhere within 12 months, 32% of the time. Among these, patients with melanoma and breast have the worst distal progression-free survival. Besides histology, location also matters. Just like with any tumor, location matters in terms of how you can resect them, but for metastatic brain tumors, if those occur that in cerebellum, they have worse outcomes because these tumors have a higher risk of leptomeningeal disease where they can spread to the cerebral spinal fluid system. And this risk is higher regardless of what type of resection you do, whether you do an in-block resection or a piecemeal resection. If you have a cerebellar type of tumor, regardless of histology, your outcome is worse. So in the United States and at Mayo, we typically try to resect only those patients that have the best prognoses, and how we prognosticate these survival is based on the RPA class, or the recursive partitioning analysis. This is a study based in 1997, and the RPA class is based on 4 criteria. It's based on the Karnofsky Performance Score before surgery, the age of the patient at the time of surgery, whether the primary disease is controlled, and whether or not they have systemic metastases. In the best case scenario, they're RPA class 1, which means they're highly functioning. They're young patients with controlled primary and no distal disease. These patients have a median survival of around 7.1 months. In this past study, what they advocated for is if you're RPA class 3, which means your functioning status is less than 70, that you shouldn't do surgery for them. You should just do whole brain radiation or palliative care, because the prognosis for these patients is only 2.3 months. So really the gray zone is the RPA class 2, which are either patients that are very old but high functioning, or patients with no control of their primary disease or the presence of systemic metastases. And what we found that when we studied these patients, there are a class of patients, RPA class 2 patients, that can benefit from surgery. So what we did is find the factors that are associated with survival, and what you found is that the factors that were significantly associated with survival were male patients, those patients with motor deficits, those patients with cognitive deficits, those with non-solitary metastases. That means they don't have one metastasis, but they have several metastases. And if their primary tumors, or if their distal brain tumor site is greater than 2 centimeters. The more factors that they have associated with this, the worse their outcomes. So if they're on RPA class 2 and they had 1 or 2 of these factors, these patients did very well, and their median survival was as much as 17 months, which is very similar to RPA class 1 patients. If they have 4 or more points, or 4 or 5 points, they're basically the same as an RPA class 3. So even among the RPA class 2, these patients can benefit from surgery. So even how you do the surgery matters. Just like with the craniopharyngioma talk, you want to do these surgeries by maximizing extent of resection while trying to minimize morbidity. And what we try to do is try to do the minimal invasive way to damage the least amount of brain parenchyma. So when the tumor comes to the surface, such as that top right image, there's really no way you can get to the tumor other than going straight through the cortex. However, sometimes these tumors can occur below the sulcal boundary, and you can see in the bottom left image. When it's below the sulcus, you can use the sulcus to access these tumors, and it's called the transsulcal approach, or by way of the sulcus. The reason why this approach is beneficial to try to minimize trauma to the brain is that you minimize the amount of brain parenchyma you go through, and you also minimize the amount of white matter tracts that are critical that you're going through. Most of the white matter tracts, which are association and projection fibers, you're going parallel to them if you're going down the sulcus, and the only thing that you're putting at potential risk down the sulcus is the transsulcal vessels, which are arteries and veins. But if you find a way to preserve these, you minimize trauma to the brain. So we try to advocate for a transsulcal approach because it decreases the working distance and maximizes brain substance preservation. And so that's a parafascicular by going way of the white matter. So another way that we've been trying to advocate for is a minimally invasive approach. So the typical craniotomy is a very large craniotomy, very large incision, which is subjected to a lot of blood loss, potential damage to surrounding brain structures, and sometimes these metastatic tumors, as you can see, can occur very deep below the surface. So a way to get down there through the surface is through tubular retractors, and in the top right image are different types of tubular retractors. There's one that I call the Vicor, which is the top right, which is more oval in shape, and there's the Brain Path, which is more circular in shape. We typically like the circular one because what it does is it allows circumferential retraction. What that means is the retraction is equidistant or equivalent in all directions, in all 360 degrees, and the tube that you're working through, however, is very small. It's about 13.5 millimeters, or the size of an American dime. What you can also do is use these through the sulcus to provide protection to the surrounding brain parenchyma, and it allows you to access deep lesions with minimal trauma. And so here's an example of, so we first started using this approach for intracranial hemorrhages. So this is a patient that was herniating. You target the sulcus, and whenever you target a sulcus, there's a very large vein or artery that overlies the sulcus. So we open the sulcus, and this is under an exoscope. What an exoscope is similar to an endoscope, but it hovers over the field, so it's outside of the body cavity. And it provides the image in 2D, but the resolution is very high, much higher than a microscope, and it has a large focal plane, so you don't have to constantly adjust it. So with this Brain Path retractor, it has a pointed tip. This is a titanium pointed tip that dilates the sulcus and dilates the white matter tracts as well as the vessels. And as you can see, we're working through a port that's 13.5 millimeters, and then we're taking out the clot under the guidance of this tubular retractor, which is protecting the brain on all the sides in equivalent pressure. And so here, after we remove the clot, and that vein was in the way, and you can see the vein is preserved. So for this intracranial hemorrhage, instead of doing a very large hemicraniectomy, plus or minus a clot evacuation, we can do a craniotomy that's 2.5 centimeters, a dural opening that's only 15 millimeters, and evacuate the clot very expeditiously and decompress the brain. As you can see, there's very little intracranial pressure in this patient. We've also been applying it to metastatic brain tumors. So here you see a very deep thalamic brain tumor that's on the dominant hemisphere. We can also do a very small craniotomy that's about 3 centimeters, a dural opening that's about 1.5 centimeters, And then we target the sulcus here, and we're once again working under the exoscope. And so we're opening the sulcus, so we're using the sulcus to minimize surrounding brain trauma. And because this is in the thalamus, it's very deep, so the conventional way of getting down here, if you try to resect it, is a very large craniotomy, very large white matter dissection, and usually using brain retractors that damage the brain surface. And so here we're working on the tumor through the tubular retractor. And if there's any bleeding, we can control the bleeding. And so there's a way for us to try a pseudo-in-block resection from this. A lot of people with metastatic brain tumors, they advocate for in-block resections to minimize the chance of leptomeningeal disease. So instead of doing an in-block resection, what we do here is dock the port on the tumor, resect the center of the tumor, and work the periphery so that we deliver the tumor in one piece, so it's a pseudo-in-block resection. Sometimes, even though you have these tubular retractors and minimally invasive devices, you can't get to these tumors, or they're recurrent, or they keep recurring. So another therapy that we commonly do for these tumors are laser interstitial therapy. What we do is we use intraoperative MRI, and we have a probe that goes down to the tumor, and it heats up the tumor using laser therapy. And based on the tip of the thing, we can contour the heat around the tumor so it heats up the tumor at the same time. For tumors, we typically use this for recurrent metastatic brain tumors, sometimes radiation necrosis, and deep-seated tumors that we don't think is safe to resect through minimally invasive means. Another thing, a clinical trial that we started at Mayo that we have at all three sites, which are the Rochester, the Jacksonville, and the Arizona site, is pre-surgical stereotactic radiosurgery. The standard of care right now for solitary metastases is a resection followed by stereotactic radiosurgery to the cavity. You usually do this within 3 weeks of the surgery. The problem with that, however, is sometimes patients have more than one metastases. So if you resect one during this 2 to 3 week time period, the other one is constantly growing. You don't have control of that site. And sometimes patients and physicians are worried to give radiation therapy because of wound breakdown. So then you have to wait even longer, and this tumor constantly grows. The other problem is sometimes these contours are very irregular. So once you resect it, the cavity is very non-conformal. So it's very hard for the radiation oncologist to radiate the site very accurately. And when they can't radiate it accurately, you have a risk of radiation necrosis because you're radiating the normal brain. Or if you don't radiate enough, you can have tumor recurrence or local recurrence at that site. So what we're studying now is we're having a randomized clinical trial to see if pre-surgical stereotactic radiosurgery before surgery is more effective than post-surgical radiation therapy. So what that means is that we have this tumor that's well conformed. They get radiation, and within 2 days they undergo resection therapy. 2 examples of cases we did are on the top and the bottom. So this is the top patient is a patient with a hepatocellular carcinoma. We radiated this left parietal lesion and then resected the lesion. As you can see, the tumor is already radiated, and the advantage of that is that we already have the conformal radiation therapy planned before, so we don't have to worry about post-surgical radiation therapy. We also have to we can minimize the chance of leptomeningeal disease, and then plus we don't worry if there's other metastases occurring because you can radiate it at that point in time. Another example is the bottom case of a patient with breast cancer, and you can see this involves the falx. So therefore, the radiation plan after surgery is very confusing. So we radiate ahead of time, and as you can see in the postoperative changes along the falx, there's some thickening. So the radiation oncologist is very unsure whether or not they radiate that area. If they try to radiate that area and it's not active tumor, there is a risk of radiation necrosis. And so these are the potential issues associated with post-surgical radiation therapy. Is there's poorly defined radiation margins, residual tumor growth during the time you're waiting for radiation, as well as wound healing delays. The advantage of preoperative radiation is you have well-defined margins before you radiate. You potentially decrease the chance of leptomeningeal disease, and there's no delay in the treatment. So even though you have all these modalities that we're trying, there's still a problem. So when you do surgery and radiation therapy, so this example is of a patient that we resected, several months later, they have recurrence elsewhere. So what do you do about these distal recurrences? Because there's no local therapy that can treat all these lesions. So the problem is that 20-30% of patients that have only primary disease in one metastasis, brain metastasis, will develop distal brain metastases within the brain. And 40 to 60% of isolated brain metastases will develop distal brain metastases. And the issue, though, is that with the therapies that are becoming widely available, including immunotherapy, a lot of these therapies are better for non-brain systemic control, but really the disease control in the brain has not been very effective. So the goal of my lab is trying to understand brain metastases. So the issue is that not all primary cells, whether that's lung cancer or breast cancer, have the ability to metastasize. So when you inject these in animal models, not very few of these cells go elsewhere and are able to establish distal disease. So the issue is, why do some cells establish metastases and others do not? That's because metastases is a several-step process where the cell has to escape the primary tumor, it has to invade the vessel, it has to survive within the blood vessel, whether that's arterial, which is a high oxygen content, versus the vein, which is lower oxygen content. The more oxygen can potentially be toxic for the cells. They have to be able to bind to the receptors at the distal site, and they have to be able to migrate into the brain and then survive any other type of organ that they try to go to. And the issue, though, is non-brain systemic control is improving, while distal disease control in the brain has not. So one of the things that we're looking at and that we're trying to establish is the presence of stem cells within these within these metastases. So within every tumor population, there's believed to be a subset of cells that have stem cell characteristics. That is, they're able to self-renew indefinitely and even differentiate along different lineages. The reason these cells are robust is that they're able to survive certain therapies, including radiation and chemotherapy, and they grow very slowly so that they're very resistant to a lot of these therapies. And so one of the things we're looking at is if these cells exist within lung cancer. And what we found is that within a lot of these cells, there's a subpopulation of cells with stem cell characteristics. Not only do they have stem cell markers, but they also grow very slowly. They're resistant to radiation and several types of chemotherapy, and that we're trying to establish whether or not they're multilineage based on the lung cancer cell lines. And so we're currently establishing that. Another problem with these brain metastases is which cells are prone to metastases. Are these the stem cells or are these other types of cells? The problem with this is that it's very hard to isolate these cells when you're culturing them. One way that we're trying to devise is a physiological way of separating the cells, and we're using what's called a microfluidic device, which is what you see in the top right. So what this microfluidic device has is endothelial cells embedded in it, similar to the blood vessel cells, and it has a tubing that goes into the microfluidic device and a tubing that goes out of the microfluidic device, and it runs continuously. So when the cells attach to the endothelial cells, we're able to separate those cells that are circulating from those cells that are attaching. And based on this, we found there's two different types of cell population with very different cell markers, which is not surprising. But when we try to passage again through this microfluidic device, they become even more selective for those cells that are able to metastasize. We're currently trying to block those receptors to see if we can change those and upregulate those receptors to see if they increase those adherence to the endothelial cells. Another thing that we're looking at is how do you treat these brain tumors when they occur? So when you have several different metastatic sites, you can't possibly do local therapy such as surgery and radiation therapy. Systemic chemotherapies aren't very effective because they're not selective in targeting. So one of the things that I studied when I was in Dr. Quinones' lab as a resident is that we use mesenchymal stem cells to treat glioblastoma. So this is a paper in the top right of Clinical Cancer Research where a brain tumor initiating cells that performs glioblastoma, we use mesenchymal stem cells to target those cells. Very similarly, we're trying to use those same mesenchymal stem cells to target the metastatic brain tumor cells. However, what we found though is that when you try to passage these metastatic tumor cells through different primary sites, so if you have one that's from the lung, and then you find the ones that go to the spine, and then you find the ones that go to the brain, with each passage to each different organ site, the selection becomes less. So the challenge that we're developing right now is trying to augment these mesenchymal stem cells to try to target these cells within different sites. And then so in conclusion, just a whirlwind of kind of the work that we're doing at metastatic brain tumors at Mayo is that metastatic brain tumors are a significant health and economic burden. Not all metastatic tumors are the same. Surgery can be temporarily effective. A variety of different approaches can be used effectively to resect and control these lesions. And it's important to understand the mechanisms behind brain metastases. And cellular-based therapies such as stem cell therapies may be the treatment in the future. And these are all the people at Mayo that have helped with these slides. So thank you.